screening trials after Urogyne surgery. First thing why we do them is that we've done studies on like our patient population that has a much higher rate of voiding dysfunction or urinary retention after these procedures. Up to 30% of women will have trouble emptying their bladder. And so the thing is, a lot of women don't realize that they're having trouble emptying their bladder. And so they could, if we don't check and we don't do some sort of test, they could go home, not empty their bladder, and then could run into a situation where if the bladder gets too full, you can start doing permanent damage to the nerves and to the muscles. And that's somewhere around 700 to 800 in animal studies is where they see that sort of thing happening, which we usually don't get that high, but just to make sure, we got to make sure that they're emptying. If they're not emptying, we've got to have a method for them to be able to empty their bladder without volition until that returns. Usually it's 3 to 4 days is all that has to occur for. So it's just like a necessary step before they can go home. We, and our post-op patients are going home the same day. We usually give them a couple hours for anesthesia to wear off and then to fully wake up before we do the testing. For my overnight patients, I'll generally do this on post-op day 1, the morning of post-op day 1. So the patients are going to come to the recovery room or be on the floor, depending on when we're doing the timing of this, with a catheter in place. With the catheter in place, we can logically assume that the bladder is empty. So I generally will kind of like move it around a little bit and make sure that it's dependent so that anything that's in the bladder is going to drain. So that we're starting off with an empty bladder. The next thing that you do is this is going to be connected to the bag. So you disconnect the bag, and then you want the patient laying down flat, because if they're sitting up, they're contracting their abdominal muscles and they're going to put pressure back against the bladder that's not going to want to feel the gravity. So they're laying flat, and then you take the catheter. If you try to feel like this, there's no water pressure, so we got to lift the catheter up. The way I think about that is everybody's been to a small town in America that has a water tower, and the reason those water towers are 20 stories up is because that height difference is how you generate the pressure to get you water pressure in your shower at home. So we simulate that by getting this as kind of as high as it will go, and that the difference in height here, you guys are all used to pressure being measured in millimeters of mercury every time you take a blood pressure. When we look at the bladder, we generally talk about centimeters of water, which is a similar but slightly different measure. So it's how many centimeters above the bladder this is lifted, and that's how we're generating the pressure to fill the bladder. So then you're going to take one of these 60 cc syringes that's got the catheter tip, throw this away, take the plunger out, throw the plunger away, and now you have a fancy funnel. And so as you're holding the catheter up, this is kind of going to be your measuring cup and your funnel at the same time. So all we're going to do is take either water or saline. You're going to pour it in here. It'll be the hardest part of your day is pouring without spilling, and you let it flow to gravity. You see how that column descends. And if it stops, you see how it stops there? That means that the pressure has equalized with the bladder. You may also have, you may see the column kind of go back the other way. That tells you that they're having a bladder spasm. Throw this down real quick. And so with the pressure that's in the bladder, I know this is 60 and then up to the top is more like 70, but by the time you totally fill it, you see that as you fill it still goes down too. So by the time you fill it, that's going to be about 100 up to the top. That's what we think of. And so you just kind of fill and ask them how they're feeling, make sure they're not getting, if they get to the point where they say, oh, that's really strong pressure, then you ask them and say, well, tell me when you think that you just can't hold anymore. And when they get to the point where they think they can't hold anymore, we don't want this to be painful for them. But you can just stop at that point. And then you can record. And so if you put 2 in and then it's down to here and you got 30 left, that's 270 in. And you can kind of do the math on that. It's not too difficult to do. We want to fill either until they get to their max capacity or until they get to 300. So we generally just don't fill past 300. Most people are going to have, since the average bladder capacity is about 300. So 3 of those will do the trick. Now, once we've got the bladder filled, if you disconnect or if you just take this and drop it below the level of the bladder, what you'll find is that now the pressure is flowing in the opposite direction and the water is going to flow out of this. So you want to make sure you keep this upright. Disconnect your funnel, Take this, and once again, if you lower this to do this, it's going to leak, so just release your bulb, and then the catheter can come straight out. Now you know how much you put in their bladder, so we can just have them go void. When they void, collect in a hat, and then just whatever's in the hat, whatever they put in, subtract the 2, and that gives you your calculated PVR. If the PVR is over 100, then it's when we're going to move into the next phase. If the PVR is less than 100, you're great. They've passed their voiding trial. You don't have to worry about it. And so what I want you to do is record the number that you put in, record the number that you put out, or that they put out, and then the calculated number that's left in the bladder. And when you call, you're just going to call our resident and let them know these numbers. And I've instructed them to always ask you for the numbers themselves, not to have you just say, oh, they passed or they didn't pass. I want them to know the numbers, and that's not an affront to any of you guys. It's just that we've realized in the past that lots of people have said they passed, and then we found out what the numbers were, and they really didn't pass. So I'm going to always ask the residents to ask you for those numbers. So, and if they pass, great. If they don't, then we move on to how we're going to help them manage their bladder until their voiding function returns.